Hello, everybody. Welcome. All right, go ahead and share my screen so we can get started. All right. Welcome, everybody. Thank you for joining us today. Today we are going to be talking about methamphetamine as pertains to community drug tracking results in the state of Washington. Um, we are joined by Cedric from the Tacoma Needle Exchange, who does drug checking there, and Leif, my coworker, who is going to talk us through some data around methamphetamine in the state of Washington. So first, we'll cover a few little webinar logistics. Only panelists and hosts are able to share their video and audio. Please enter your comments and questions in the chat for the QA section. We will pause occasionally and respond to the chat if those questions relate to the topic that's being covered at the time. If not, we will have some time at the end to cover all the remaining questions. And lastly, most importantly, please be respectful and stay curious. And also, this webinar is being recorded, so it could be shared out later. So with that stuff covered, we'll just go ahead and get started. The agenda for today. Oh, yeah, Hannah, I see your hand is up. Maybe. I actually don't know if you'll be able to unmute yourself. Um, Make sure to keep a eye on the comment section. So the agenda for today, we're going to overview the Washington State Community Drug Checking Network, or the CDCN. If you've joined us before for these webinars, it's just a little overview of the network. And then next we'll cover some methamphetamine data from a few various sources: fatal overdoses, police evidence testing, and drug checking data. Um, And sorry, don't worry about accidentally raising your hand. I just wanted to make sure I wasn't missing anything. And then we'll have Cedric join us for the drug checking and his experiences as a technician offering drug checking services, particularly to folks who either primarily use methamphetamine or just bringing a methamphetamine sample to be checked. And then we'll answer those remaining questions and cover some resources. All right. So first, covering just very, very quickly, broadly, what is the Washington State Community Drug Checking Network? It's a partnership of various organizations around Washington State, which provide community level drug checking and related harm reduction services. ADAI's role in that is providing operational support and technical assistance in collaboration with Public Health Seattle King County. I am the day-to-day operations program manager, so my role is sort of a communication liaison between the university, other community stakeholders, and then the sites and technicians that are offering the drug checking services. And lastly, the whole network is funded by the state healthcare authority. So just one more level of detail about the community drug checking network. So there's kind of two models that are currently operating in the state of Washington. There's 8 sites that are using an FTIR Fourier transform infrared spectroscopy, which is little drug checking equipment, kind of looks like a little microscope, and gives sort of an overview of various substances within a sample. They also use immunoassay test strips, or just test strips as they're commonly referred to as. And then most of these samples are then sent out to a secondary laboratory where they use different forms of mass spec to provide a little bit more different level of detail to that sample. There's 3 sites who are using only test strips, no FTIR, referred to as the light sites. And then most of those samples are also sent out for secondary lab testing using mass spec. One thing to note is that the 8 sites using the FTIR have staff time paid for by ADAI. So a lot of the data that will be seen today that is from the drug tracking is from those full sites. So covering sort of the ground level or framework for this whole webinar, I thought it was important that we look at why folks are bringing in methamphetamine samples to be checked at drug checking sites. And by doing that, it's important to sort of look at a little bit of a history to help us have a better framing or a perspective around the data that's going to be shared, and make the content that Cedric is going to cover be a little bit more relatable. So we'll just cover some quick history. Um, so fentanyl quickly replaced most of the heroin supply in the Pacific Northwest. It was pretty abrupt, this transition from the availability of heroin and folks using heroin into fentanyl, starting with those M30s, the blues. Uh, so this widespread and super fast availability of fentanyl in the drug supply market, being that it's a much stronger opioid than heroin, it obviously increased the community-wide risk of overdose. So in response, alongside the saturation of naloxone in the community, fentanyl test strips, which were originally intended to be used for urine drug screening, were sort of repurposed and distributed broadly. And folks began testing their drugs before consuming them for the presence of fentanyl. The problem with this response primarily was just the high rate of false positives that were occurring when testing, particularly methamphetamine, MDMA, and Molly. Um, so when using these test strips, it took a while for the community to sort of have studies done and do a lot of like tinkering and stuff to figure out that with methamphetamine, particularly, you needed more water to dilute the sample more to get a ratio where you weren't getting these false positives. So that situation and rollout sort of created this an experience that I had when I was working at the needle exchange here in Portland for a few years was that folks were getting a lot of false positives and this sort of, I mean, totally understandable concern about fentanyl being in the supply, which was also very sensationalized and really put out loudly by the media that fentanyl was in all of the drug supply. So that on top of all these false positives with these repurposed test strips, um, created this fentanyl in meth sort of situation that we hear a lot about and I've heard a lot about. So here's just a look at that in sort of a visual way. You see the news headlines over here on the left-hand side talking about fentanyl being mixed into other drug supply, particularly stimulants. And then on the right-hand side, there was a study talking that looked into the high concentration of stimulants causing false positive with fentanyl test strips. Myra Lieberman is huge in the drug tracking world and it was really awesome to take that on. And then in the bottom right, it's just a little another image that is talking about issues with certain lots of fentanyl test strips, which then got confusing, like what lots are have a higher risk of causing false positives. And yeah, so it's became a little bit of a hard, tricky situation to navigate. And then hopefully we can provide a little bit more of perspective and framework for the data talk that Leif is about to provide for us all.
It's been, pardon me. Do you mind if I share my screen? Alrighty, hopefully everyone can see that. So, hi again, my name is Leif Layman, and I'm the data manager and coordinator for the Washington Community Drug Checking Network, the CDCN. And I'm going to kind of begin this section by bringing into context some of our interest in tracking methamphetamine as a drug of concern. And I just want to remind you to kind of keep your questions in mind or write them down, and I'll take a few pauses to kind of give an opportunity to ask questions about data because it can get kind of dense at certain points. All right, so first off, I kind of want to ground us into the facet of public health burden of methamphetamine. So looking at methamphetamine involved deaths. Now, these data describe the mortality attributed to methamphetamine alone or methamphetamine and a combination of other drugs, including alcohol, benzodiazepines, and barbiturates at the kind of in the green, the cocaine and meth in the blue, opioids and cocaine and meth in the kind of reddish, and opioids and methamphetamine in the orange, with methamphetamine alone in the kind of purplish bluish color there too. So on the y-axis, we have deaths per 100,000 state residents. And on the x-axis, we're looking at the years from 2003 to 2023. And some of the key observations that I want to make are that the total deaths involving methamphetamine have grown substantially since 2010, from fewer than 5 deaths per 100,000 residents to around 25. And in 2023, and you can see that's about a 5-fold difference. And I also want to point out that in 2020, you can see that this rate kind of changed or accelerated. There's kind of a steepening of the curve there, more than doubling the deaths per 100,000 between 2010 and 2023. Overall, deaths involving methamphetamine and opioids continue to represent the largest fraction of methamphetamine deaths since around 2013, 2014. And deaths involving cocaine and meth and opioids have started to increase in recent years, as you can see in kind of the reddish color there. And now I'm going to move on to meth among kind of local police evidence testing. So these data are crime lab data that kind of show another perspective of methamphetamine use in Washington state. So primarily, these represent street level possession and kind of small crime seizures of drugs submitted for evidence testing. These do not necessarily represent large busts from the federal government, from agencies like Customs or the Drug Enforcement Agency. So first off, I kind of want to mention a caveat that you can kind of see here that these results are subject to bias due to policing priorities and kind of what is submitted to evidence testing. And part of that is what I'll get into in a minute, which is that pseudoephedrine was placed behind the counter. It's a nasal decongestant. You may have gotten it if you ever had cold or flu, and you go to the pharmacy and you have to present your ID to kind of and maybe sign something to get your drugs. And that was used as a kind of primary precursor for manufacturing methamphetamine in Washington. And you can see that when that was done in around 2006, there's a substantial kind of drop in the number of the amount of evidence submitted for testing. And then the Blake decision in 2021 found that the law that criminalized drug possession in Washington state was unconstitutional. And you can see in this kind of grayish area on the far right-hand side of the graph that there's, kind of a precipitous drop in not only methamphetamine, but almost all of the other drugs. They're just kind of in smaller amounts so that there's less kind of variation between years. So just looking at this graph, the y-axis is the count of cases submitted to crime lab for police evidence testing. kind of like I mentioned, and then this includes years from 2002 to 2023 as well. So overall, you can see that methamphetamine, which is in the dark bluish color, far and away kind of outpaces all other drugs in this graph. It's the most common in all years except those years following 2022. And the number of methamphetamine positive cases was increasing from around 2009 until 2019. And then obviously the Blake decision happened. But even after that, you can see that there's, kind of a drop, and then it continued to increase, though at maybe a lower rate. And the only other kind of thing that I want to mention is that there is some variability here. And, you can see that other opioids, which is in this kind of top light blue color. And what I want to hone in on is, let's see, maybe I can do a laser pointer. This section here where other opioids kind of outpace methamphetamine, and that is largely due to the presence of fentanyl. But opioids or methamphetamine still being the second most common. All right. So what can we kind of observe? So methamphetamine involved deaths are increasing and have increased in all years since 2010. Likewise, cases in which evidence was collected testing positive for methamphetamine increased each year until the Blake decision, which changed the criteria, but the trend continues to increase. And from these data, we can kind of imagine a variety of things are happening, which include the number of people using methamphetamine might be increasing, resulting in more crime lab evidence and deaths. And that can kind of happen just simply due to a larger population of people using methamphetamine. And, that results in just more of this kind of variation. We can also see that, potentially methamphetamine use behaviors have become more hazardous. And in part, we can see that due to a greater proportion of people using methamphetamine and opioids at the same time, the potential hazard of that use is greater than either alone. And then there's also this kind of more novel idea that chronic methamphetamine use is toxic to the body, and that some of the results that we're seeing where the median age of methamphetamine only deaths has increased significantly in the past decade, which suggests that there might be kind of a cohort effect going on where people who are using meth are getting older, and then some of the chronic disease aspects that are commonly associated with age, particularly cardiovascular death or cardiovascular disease, there's synergy between methamphetamine and cardiovascular disease, resulting in a higher kind of rate of mortality among that group. And now I'm going to get into the Washington Community Drug Checking Network test results. So we're looking at almost a year of data from March 21st, 2024 to January 31st, 2025. So just 2 months ago. And then the samples that are included in these results are samples that were either sold as methamphetamine or contained meth, but were not sold as meth. So it could be sold as fentanyl, cocaine, or other substances that people might be wanting to use. And then I do want to mention that all the results that I'm going to present here are those from confirmatory laboratory testing, from an analytical laboratory. So like Ben mentioned, the techs who perform some of the FTIR testing on site will send results to subsequent laboratories that will test these results with mass spectrometry, and that's what results we're seeing. All right. So first off, I kind of want to give some caveats, which are that these results come from a non-random sample. People are volunteering to have their drugs tested for, a variety of reasons, but that introduces kind of non-randomness to the sample. And so they're not representative. So there's no way to know what segments of the population we're sampling versus what is being missed in terms of, people who are using drugs out in the community that, are not accessing services or not interested in drug checking. There's no way to know what we're not getting. I also want to mention that these results can be subject to cross-contamination. So, while certain individuals may use very good kind of laboratory practices with their substances or drugs that they want to consume, there's no way to rule out that people might be carrying baggies of various substances together or things like that that cause cross-contamination. And then these data are somewhat inexact in that not all substances can be detected by the methods that were described. And there's also the possibility that when testing a sample, it doesn't necessarily contain all of what is in kind of someone's substance. So if they take a very small amount and send it for laboratory testing of a larger sample, then that doesn't necessarily mean that that small amount is representative of the entire kind of volume or amount that someone has in a baggie or what have you, and that can result in a sample not being exactly representative of what's in the kind of bulk. However, they can support more informed use of drugs. Participants can learn about what's in their drugs and use more safely. It can also help us as a population kind of gain a better idea of how certain drugs are occurring in the drug supply. And it can also help us to detect the presence of adulterants or emerging substances of concern, such as xylazine, nitazines, fentanyl analogs, BTMPS, just to name a few. And just to recap, we're going to kind of review and discuss what samples were sold as meth, and then what samples contained meth, but that were not sold as meth. All right, so among samples that were sold as meth, most samples that were sold as meth had meth. And this is the vast majority. So 99% of samples that were sold as meth contained meth. Only a minute amount did not, and it's too small and inconsistent of a sample or number of samples to derive any real insight. I did summarize them here, but there's not a lot to be gained from that small amount. Now, among samples sold as meth, I wanted to talk about kind of what was detected with the meth. So there were 405 samples that contained methamphetamine, and we also detected a couple other substances that co-occurred with the methamphetamine. And those were BTMPS, or bis 2266 tetramethyl 4-piperidine sebacetate, which is a filler, sebacate, which is the filler and a chemical that is used in plastic manufacturing. That occurred in one case, with a very small proportion of the 405 samples. MSM, or dimethyl sulfone, or methyl sulfonyl methane, which is a joint supplement that is sold over the counter, occurred in 19 samples, and that's oftentimes used as a filler. And then dimethylamphetamine occurred in 30 samples, and that is a manufacturing impurity with another methyl group added to the amine of the methamphetamine. That is less potent, generally not psychoactive, and that occurred in 7% of samples. So generally, what we saw was that methamphetamine contained methamphetamine with a small amount of samples containing. ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... ...... And I kind of just said that, but the other substances that were detected with methamphetamine were generally not considered psychoactive. They're manufacturing impurities, they're fillers. That doesn't mean that these other substances are necessarily safe to consume. Smoking, snorting, or injecting them may not be safe. While you may be able to orally take a joint supplement, doesn't mean that other forms or other ways that you consume it are safe. But that is kind of the gist. But the takeaway is that samples that were sold as meth generally contain methamphetamine, and that was 99%. All right, so I'm going to pause for a moment and ask if anyone has questions about what was found in samples sold as meth. So I'll stop sharing and I'm going to look at the chat if anyone has questions they want to add there, or if they want to raise their hand.
There's also a question in the Q&A, Leif. Do you want me to read
Yeah,
it to you, or do you want to read it? Okay.
No, I can see that. So the question is, can you discuss any impacts of the national prescription stimulant shortage on the meth supply and meth use? And honestly, no. Unfortunately, we don't really have data to support that. I will talk a little bit about a few samples in a bit that were sold as amphetamine, but we don't have, that's not something that we see a lot of, or have a strong sense of people, taking kind of street or, illicitly acquired substances for to replace their prescription stimulants. Right. If there are no other questions, then I will continue. All right, so now we're going to move into samples that were not sold as meth, but contained meth. Okay, so sold as what? Almost 3/4 of the samples that were sold as something other than meth, but contained meth, were a form of fentanyl. The kind of 80 or the some other chemically related drugs, including amphetamine and MDMA, were also found to contain methamphetamine. So that, kind of getting at that question about prescription stimulants, but again, like I said, a very small amount. And so we really have limited identifiable patterns otherwise. We're talking about less than 5% of samples containing, heroin, cocaine, MDMA, ketamine, DMT. These aren't really these kind of one-off samples or cases could represent cross-contamination at consumer level or dealer level, and they also might represent kind of knockoff drugs, either prescription drugs, substituting meth for amphetamine, or just kind of knockoff MDMA or ecstasy, Molly, those types of things. But no strong signals, just kind of high variability in what samples were sold as that contained meth. Looking at samples that were not sold as meth but contained meth, but what actual substances were present. So, before we were looking at what they were sold as, now looking at the substances that they actually contained, you can see that 100% contained methamphetamine, right, because they contain meth. So I want to give that to kind of ground us in there. But you can also see that, 70%, more than half, or excuse me, 60%, more than half had fentanyl, which, makes sense given that there were 82 that were sold as fentanyl, and then 70 contained fentanyl. So there's, approximately similar amounts. And so it's not surprising to see that, certain things sold as fentanyl contained fentanyl, but then they also contained methamphetamine. And then, consistent with that, we kind of have fentanyl precursors and analogs, acetaminophen, anesthetics, BTMPS, and xylazine in this, in substances that co-occurred here, which is consistent with samples sold as fentanyl. Like I said, possibly indicating cross-contamination from methamphetamine just being present, especially among people who, or among samples from people who might use fentanyl and methamphetamine, of which there's a population. And then just looking at samples containing meth, kind of recapping, mostly these samples that contained meth were fentanyl, 70%, and were sold as fentanyl. And of these samples containing meth, most of them also contained fentanyl, 60%. So, there's that 10% difference there. But that's kind of the general trend, I would say. And then we also had a small amount that were sold as amphetamine, but only one actually contained amphetamine. And so, we could kind of surmise that might be due to, people looking for amphetamine to replace their, prescription stimulants, but not sure. And then these samples also contained substances that were largely consistent with samples sold as fentanyl, which, makes sense. They were sold as fentanyl, but also contained methamphetamine. So overall, it's pretty difficult to summarize. Otherwise, these samples represent a relatively small number in terms of our overall samples. There's not really a way to know the amount of one drug in these samples relative to another. So, in drugs or in samples where there was fentanyl and methamphetamine, we don't know the relative proportions of those substances when compared to each other. So, there's not a way to know that, the methamphetamine was only present in a very, very small amount, which might be more indicative of cross-contamination. Whereas, if there's equal amount of fentanyl and methamphetamine, that might indicate a different kind of signal. And then I also want to note that, there's still the possibility for unidentified cross-contamination, and that, can really, mess up the classification here, where we don't really know what we're looking at, even though it was sold as something. And just kind of to summarize, it looks like many of the cases where there was methamphetamine that was in a substance that was sold as something else, it looks like cross-contamination with fentanyl, and perhaps some knockoffs of amphetamine and MDMA. All right, and then I'm going to give some examples of the samples that we've seen. And on the left-hand side, you can see kind of a variety of sample types. We have some in crystalline methamphetamine up here and down here, some powder, and we have kind of various different substances that occurred alongside the methamphetamine. So down here in the bottom left, you can see that MSM or dimethylsulfone combined with meth here, dimethylamphetamine here with the kind of magenta background. And, there's not necessarily an identifiable pattern here. And then also looking at the right-hand side, which these are pictures of samples that contained methamphetamine that was not sold as meth. There's a little bit more variety. There are some pills here. This looks like kind of an M30 pill, as well as, some kind of crystalline and powders here and here. The kind of takeaway when looking across, samples that were sold as methamphetamine on the left-hand side, that had meth, and samples that contained methamphetamine but were not sold as meth on the right, you see that, there's not, you wouldn't necessarily be able to identify these substances based on just looking at them. You can see kind of powders and crystalline samples on each side, although, pills on the right. Though I wouldn't say that is necessarily representative. All right, kind of a whirlwind. So we're going to look at, now we're going to talk about questions about what was found in samples not sold as meth but contained meth. So I'll take a pause here. All righty. Are there any questions in the chat or in the Q&A?
I didn't see any questions. I did see an interesting comment where someone shared that individuals are also scared to use meth IV because of the fentanyl. And someone else shared that at their clinic, they do have patients who report using meth instead of getting an alternative to treat their untreated mental health issue. We do refer people to mental health evaluations to see if there's an ability to replace their meth use with something that isn't as harmful. So no questions, but interesting comments, and thank you.
Yeah, this is interesting. Yeah, and again, like I said, we don't necessarily have the data to support that, happening among people who are having their drugs checked at, our sites, but that certainly does not mean that that's not happening elsewhere. So I do want to acknowledge that, we don't have all the answers for that kind of thing, but we don't necessarily have the data to support that. All right, I will finish up here. Just with this kind of summary where, most drug checking samples sold as meth contained methamphetamine. They also might contain fillers and impurities. And that is consistent with what kind of the DEA data for the Drug Enforcement Administration suggest, which is that meth is generally very high purity when it is present. So that kind of corroborates that point. And then among samples that contain meth but are sold as something else, it looks like the other samples were sold as fentanyl or appear to be knockoffs. So just to reiterate, it looks more like methamphetamine occurs with fentanyl than fentanyl occurs with methamphetamine. And I think that's an important point to get across, given kind of the confusion about, is there fentanyl in my meth? Or it really looks more like the opposite is the case, where meth might be in fentanyl if there's, any kind of crossover or there's cross-contamination going on, but we can kind of make up ideas about why this is happening, but we don't necessarily know. This is just kind of what the data are showing. And with that, I'm going to pass the talking stick to Cedric. Thank you all.
Good afternoon. My name is Cedric Picard, and with Carl Cook. I work at the Tacoma Needle Exchange. We lucky and privileged to use the FTR spectrometer, which is an amazing machine because it gives us definitely a better understanding of the supply. So the test strips are an amazing tool, and we've been using them for a long time. And Leif mentioned it before, and Ben also, they can create some false positive. It's not like they only create false positive. They're not used properly. People get confused. They don't really know what's going on. And because the words of the streets is methamphetamine has fentanyl, or fentanyl is in everything, you really need to show it to a participant through the spectrometer. It really is very, very clear. It happens every once in a while that we see what I will call cross-contamination, and this is something that is discussed with the participant. We found out eventually that they've been using both and they're not too cautious. So thank you, Ben. This is on the left-hand side, you can see basically what we get when we use the spectrometer, and it's spectra. So the blue line is a typical spectra of methamphetamine. And this sample, something was very suspicious. You can see those three circles. So the first little bump around 3,200 and 3,400 will be something called mannitol, which is a filler. And further to the right, where I put fentanyl pick, it's at 1650, which is absolutely unusual with methamphetamine. And there's other bumps a bit further down. So this is when it raised the question is, what's going on here? Because somebody brought me some methamphetamine and there's obviously other stuff. The staff at the Needle Exchange, every time they see a spectra of methamphetamine, they know it right away and matches 100%. And we all agree that methamphetamine is meth, and cross-contamination does happen, and we see that. So while we do use a spectrometer, we also do the test strip, and we're lucky enough that we can use a couple different ones. So the BTNX, which I really like, the DenSafe, which I'm not a big fan of because a lot of time it will create a false positive, which is usually due to dilution ratios. We use the xylazine, the methamphetamine, and the benzodiazepine. So on the result here, we knew right away there's something wrong. The test strip confirmed that. And after that, we send everything to the lab, and the lab confirms everything. That sample, methamphetamine, contained fentanyl analog, and some mannitol. And what's very interesting here is like you can start a discussion with a participant and say, hey, I see fentanyl in this. Do you happen to use fentanyl, or do your friend use fentanyl? And it will make it very clear that the participant will be, yes, I do. And yes, maybe I should be a little bit more cautious. Now, most of the sample that we see on methamphetamine are definitely not contaminated with fentanyl, but our participants are really, really suspicious. And when they see the spectra, they all believe that, oh, wow, it's really methamphetamine. It makes them very happy. Not that they should not be cautious. But it also reassures them, and it sends a very good message to the community and the people that use methamphetamine. So thank you, ADAI. Being able to use a spectrometer just makes a huge difference, really, really a big difference. And I know not everybody can use that tool, but anybody's welcome to come and get their drug checked at the Needle Exchange, all the other sites, because it really makes a big difference.
Yeah, I'm kind of glad you pointed that out, Cedric, particularly. So like if somebody is like methamphetamine is sort of their sole choice of drug per se, and they're bringing it in to be checked. If you don't have the FTIR, what would you use? All the test strips? Would you use like what would be the benefit of having, say, a methamphetamine test strip if you don't have an FTIR and somebody's getting their meth checked?
So originally we were only using the fentanyl test strip, and they're finicky. And I've seen a lot of false positive or wrong dilutions. So adding the methamphetamine test strip makes a big difference, right? But that doesn't mean that there's no fentanyl, because you can get a false positive from that test strip. The BTNX are fairly accurate, but the number of people that say there's 2 line, it's positive, COVID testing, 2 lines positive. Instructions in the back, but people do their testing outside in the streets, it's not necessarily ideal. And so sometimes the second line is pretty fainted also. You can't really see it. So tests are good, but like anything else, they're not 100% accurate. But yeah, being able to use the methamphetamine adds a little extra confidence of what's going on for sure.
Yeah, the whole like layering of information that you're able to provide folks, because I think drug checking, whether methamphetamine specific or not, it's a unique and really powerful opportunity to provide information in this sort of information vacuum that is drug supply, as well as validating people's experiences, whether it's not necessarily aligning with their experiences, but in a way, in and of its own way, is validation, right? So like if somebody is, oh, this meth tastes really funky when I smoke it or something, well, you might be able to notice something on the FTIR that maybe could attribute to the taste, might not necessarily. Or, if another drug shows up, like you said with the whole cross-contamination conversation, right? It's this very unique opportunity to engage with folks.
Yeah, the tool is really to make our participants feel more comfortable with their purchase and their experience. There's a limitation in the spectrometer, which is less than 5%, but methamphetamine is methamphetamine. But we can find other stuff if there's something else, but usually it's not the case. And I've seen people literally like gaining up and running out, they're so happy and pleased that it's just methamphetamine. Say, hey, wait on a second, it's still methamphetamine. You still need to be cautious. But it's just reassuring, very reassuring. And I think it's very important to provide that information to our participants.
So a little bit about cross-contamination, and I think there's another point too, right, with the ongoing sort of conversations around methamphetamine use in general. Um, Cedric, when you, sorry to put you back on the spot, is there other harm reduction messaging that you might use or have other people heard other people use when somebody says, well, there must be fentanyl in this methamphetamine because, I smoke it and I fall asleep, or, you know, um, yeah, it's got not a stimulating effect and I think there's a downer in it or something like that.
So we all know that after about 3 days, no matter what, and if you keep on smoking methamphetamine, naturally your body will get tired and eventually you'll fall asleep. Your internal clock works that way. And I'm not a doctor, but this is why I understand. And using more and more, you becoming more tolerant also. Now, what I found out, especially if there's a cross contamination, is because people are sharing their supply and other tools, and it's because there's a big shift. People used to inject methamphetamine, and now a lot of them smoke it, which they believe it's safer. But if you share your pipe with somebody else, and if that person been using fentanyl and you're going to put methamphetamine on it, that's going to have some pretty bad effect, So it's always about education and trying to get a participant to understand that whatever tool you're using is yours and it should not be shared. I believe you can share your supply, it's yours, you do whatever you with it. But the tools are very personal. Uh, and they, a lot of them just wake up. And when I say those kind of words, you know, yes, I'm an older person. People call it the dad words. No, I just want to make sure they're safe and you don't share a pipe, period. Like you wouldn't share a syringe. We give enough. If you're willing to have some, we give them away all the time. You know, please don't share them. They're personal. That's very, very important. I think message.
Yeah, thank you so much. I mean, I applaud you all the time, but yeah, that it's such a beautiful, delicate dance to validate a person's experiences in such a vulnerable space while also seeing these opportunities and having the sort of skill set to give those messages and the sort of harm reduction things, education pieces to folks without dispelling their experiences, um, or making someone like feel dumb that they didn't know these things. Or, and I think it also goes to show like how much love and support is in the community of people who use drugs, and like they want to look out for each other. We want to help each other and you know, keep each other safe. So I think you hit on some really crucial points. Um, and yeah, thank you and Kyle and all of the other technicians for the work you do. It's not easy, and it's a pretty unique and heavy spot to be in all the time, but I couldn't imagine a better person to do it. So um,
If you don't mind, you know, I think what's empowering is letting people know what they're using, making them feel more comfortable. You know, that's the key here. We're not here to tell you you have to stop. No, 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 no. We're here to tell you this is what you purchased. This is what we see. Hopefully it helps, you know. And they come, they trust us. They want answers, and we're trying to find answers because we respect our choice, and that's what's important. You know, if one day they decide to stop, which happens every once in a while, we'll help them out. But this is not the message here. The message is this is what we found. Yes, it is safe. Oh, please be cautious. It is not safe. You know, that's it.
yeah, thank you. Cedric, everybody, what a wonderful person. So yeah, I think we're at the point we'll just go through if there's any Q&As or anything in the comment section. I'm gonna stop sharing my screen so I can check easier.
And there's a question in the Q&A
Thank you.
about Seattle-based locations for drug checking.
Oh yes. We should have a directory, a light directory. I will say, you know, it's like Cedric said, there's a lot of trust from participants and people in the community. And drug checking is still a new and unfamiliar territory for a lot of folks. So, understandably, not all sites are public with their services quite yet. Um, but there is a light directory that is available on CDR's webpage. I don't know if you can like pull it up really quick,
Yeah, I put
Allison.
the link in to the web page, but I'll do that again. But it doesn't list any King County sites currently.
Yeah,
Which is fine. I think just check back on it. That page will be updated regularly as sites decide if they want to participate or not. And you can also reach out to Public Health Seattle King County to see if there's any resources in your area.
hey, thank you, Allison. Yeah, we revisit the conversation quite frequently. So yes, please keep eyes on that. Um, The machines, yeah, they were purchased through ADAI on a grant from the Healthcare Authority, most of them. A couple were paid for by Public Health Seattle King County that operate in King County. All right, let me give one more minute. And then we'll make sure at least the resource slide, I would imagine all the slides will go out. Yes. Walla Walla, Blue Mountain Heart to Heart. Malia is the technician out there. Wonderful, wonderful human being. That information is on the website in that light directory. So cool. Just give like another minute or so.
Ben, while we wait to see if any more questions come in, I just want to put in a plug that this is part of our Focus on Meth series. We've done quite a few webinars now on topics related to methamphetamine. We have one later this month about syphilis, HIV, and hepatitis C among people who use meth, and then one in April on meth use among men who have sex with men, as well as a symposium on June 12th. So check out the webpage and sign up. And maybe there's one more question.
Is there needs-based test distribution, especially outside of the western section of the state? Needs-based test distribution. Are you talking, anonymous. So if you're talking like an organization obtaining test strips to distribute, Department of Health is probably your go-to. And then if you're talking about just personally obtaining, it would probably just be your local harm reduction site. I imagine, I think most of the SSPs at least get various test strips through DOH, Department of Health. So hopefully that answered your question. Okay, cool. Well, thank you everybody for joining us today. Big thank you to Cedric and Kyle for holding down the Tacoma Needle Exchange drug checking, and Cedric for being here and providing such wisdom. And yeah, and Leif for the data. Sorry, there was a question that popped up. Leif for all the data, really laid out in a nice way. And I think we got a nice little insight as to why folks are getting methamphetamine samples tested, what information can be provided, and then, you know, a little harm reduction messages based off of those things. So yeah, that'll being said, really appreciate you all, and we'll see you maybe at another webinar, maybe at the Meth Symposia. Cool. Thanks, everyone.